In this video, here's what we'll cover: why depression keeps coming back, what MBCT actually is, changing how you relate to thoughts, what the evidence shows, who it suits, and the caveats. You've been well for months. The therapy helped, the fog lifted, and life felt like yours again. Then one grey morning a small disappointment lands, and something in your mind whispers, "Here we go again." Within days the old heaviness is creeping back. And the questions start. Why does it keep returning? What am I doing wrong? If that sounds familiar, I want to say one thing clearly. You are not doing anything wrong. Depression returning is not a sign of weakness or failure. It has a real basis in how the mind and brain work, and it is something we can work with. In my practice, this is one of the most common experiences people bring to me, and there is an approach designed for exactly it. Let me start with the puzzle that MBCT was built to solve. By the early 1990s, we knew cognitive therapy was very good at treating a current episode of depression. What was far less clear was how to stop the next one, and the figures were sobering. After a single episode, the risk of a second is around 1 in 2. After a second episode, the chance of a third climbs to roughly 7 in 10. After 3 or more episodes, the risk of it returning again sits near 90%. The scientists who developed MBCT found a key driver behind this. They called it depressive rumination. That is the repetitive, circular dwelling on how you feel, what it means, and why it is happening. Rumination does not lift depression, it deepens it. And for someone with a history of depression, even a small dip in mood can quietly switch on this whole cascade of negative thinking and pull them back down. So what is MBCT? It stands for Mindfulness-Based Cognitive Therapy, and it was formally set out by 3 cognitive scientists in a book published in the early 2000s. I want to be clear from the outset. MBCT is not a meditation app, and it is not a wellness course. It is a structured, evidence-based clinical intervention, built specifically to address what drives depression coming back. It is usually delivered as an 8-week program, either 1-to-1 or in a small group. It weaves together several threads. There is education about depression in the part rumination plays. There are mindfulness practices, like the body scan and the 3-minute breathing space, built up gradually week by week. There are cognitive exercises drawn from CBT, and there is a personalized plan for spotting your own early warning signs and responding to them skillfully. Daily home practice matters too, because MBCT gives little benefit without it. Here is the heart of how it works, and it is a subtle shift. In standard CBT, you examine a negative thought and change its content. You weigh the evidence and build a more balanced view. MBCT does something different. Instead of changing what you think, it changes how you relate to it. The core skill is sometimes called decentering, or metacognitive awareness. It is the ability to watch your own thinking rather than being fused with it. When someone can notice, "I am having the thought that I am worthless," and see it as a passing mental event rather than a plain fact. That small step of awareness is often what stops the thought from triggering a downward spiral. You are not fighting the thought or suppressing it. You simply let it be there, and let it pass. Both CBT and MBCT have their place, and in my practice I often use them together. Now, the evidence, because I think you deserve to know it. The landmark trial, published in the year 2000, found that for people with 3 or more previous episodes, MBCT cut the relapse rate from around 2/3 to just over 1/3. Over a follow-up of more than a year, a later meta-analysis, pooling patient data from 9 controlled trials, found MBCT worked about as well as staying on maintenance antidepressant medication for preventing future episodes. That last finding matters especially for people who want to reduce or come off antidepressants but worry about relapse. MBCT offers a genuinely evidence-based path worth considering, though any change to medication is always a decision to make with your GP or psychiatrist. The benefits reach beyond depression too, with good support for generalized anxiety, chronic pain, and everyday stress. So who is MBCT best suited to? The strongest fit is people with recurrent depression, especially those with 3 or more episodes, people wanting to lean less on medication, and anyone who recognizes rumination as a central pattern. It also suits people who want practical, portable coping tools for daily life. But I want to be honest about the limits. because good practice demands it. Mindfulness is not right for everyone, at least not without careful introduction. For people with significant trauma histories, deliberately turning attention inward can sometimes amplify distress rather than ease it. That is a recognized clinical reality, not a rare footnote. So before I introduce sustained mindfulness, I assess each person's readiness, history, and current stability. Where there is trauma, we build grounding and coping skills first, and start gently. This kind of clinical judgment is what makes MBCT with a trained clinician different from a self-guided app. If any of this sounds like your experience, whether it is depression that keeps returning, a wish to rely less on medication, or a mind caught in rumination, MBCT may be worth exploring. You can read the full guide, or book an appointment, using the links below. We would be glad to help you at Potentialz Unlimited in Bella Vista. Before you go, here's a quick recap of what we covered. Why depression keeps coming back. What MBCT actually is. Changing how you relate to thoughts. What the evidence shows. Who it suits. And the caveats. And one small thing that really helps more people find this. Subscribe for weekly mental health explainers. Like this video if you found it helpful. Share it with someone who might need it.